Is it working? There. Good afternoon. My name is Raphael. You'll have to excuse me a little, but I'll have to read a bunch of notes I made here because when I was invited to speak, I decided to talk about this topic that I've been gathering information on for, I don't know, 6 years. And I already have about 400 pages written. And I had to summarize this in this lecture. So, since I'll have a bunch of notes, I won't go moving around like the others here, like Magda went down and everything. I'll stay a bit more at the podium. Here is a bit of the resume, some relevant things to this area of biological dentistry. Well, I don't even have a digital presence, but after this Congress, I intend to start and so on. I will make a lot of this content available on the future website, which I've been saying for a long time, but it's already ready.
Yeah, and also start on Instagram and such.
Well, this topic came up for me for two reasons. One of them is our communication error. I include myself here in biological dentistry and a lack of explanation for cavitations in regions without extraction and without trauma. I'm not considering internal trauma, more a matter of external trauma. So then for me to understand and later explain, I've been gathering material for some years now. I separated something I'm calling a book for now, and in an introduction, a linguistic treatise and a cellular biochemistry treatise. This linguistic part, I will start with it. I tried to give a good summary. I didn't want to go on too much because it's a slightly more tedious topic, but I find it extremely necessary because the theory that follows comes from the diagnosis of this problem. So, what I observe is that doctors, dentists, and patients are not able to explain exactly what cavitation is. The phrase NICU is a wrong healing, from my point of view, is causing confusion in people's minds, and we have serious patients who are not being diagnosed. I see a lot in WhatsApp groups, team, for those who have courses should also observe people, doctors commenting when they send tomographies, exams to evaluate, saying in such region, there is no NICU because there was no healing, there was no extraction. And I believe that the origin of this problem is what I try to describe in this linguistic treatise. The problem is old. Dr. Buku himself, I exchanged some emails with him. He made all his material available to me. And even he, in his articles, comments on the variety of nomenclature. For those who don't know, Dr. Buku is the one who gave the name NICU. This acronym for neuralgia induced by cavitation osteonecrosis. On Tuesday, in his course, Dr. Lechner himself told us that pain is the second leading cause of suicide in the world, only behind depression. I don't remember if it was in the world or in Europe, but in fact, a patient of Dr. Bukot, there is this account, he committed suicide and left his body for Dr. Bukot to analyze. Who knows, maybe Dr. Bukot gave it this name, mycosin, yes, with talking about the symptom because he was impressed by the number of pain cases he observed. And these cases are really, really striking. I have already received cases of Miko, but there is one that was very emblematic.
The patient came to me like this.
In 2023, a woman, 48 years old, 8 years of pain, 4 years using morphine 15 times a day intravenously. Her husband arranged a scheme even with the ambulance staff there to buy the morphine and administer it himself. Intravenous, right? And 2 years without leaving the house, in a dark room, afraid that any movement would cause pain, and she was wishing for death. The patient told me in front of her family that she couldn't take it anymore, that she had already done everything, did all those procedures. Transcranial magnetic stimulation is shock to the head. And she didn't know if she would last another week. That to me was an urgent emergency situation. She was already talking about suicide to her own family. Her own daughter came. I don't know if you followed the case of a veterinarian at the end of last year who was doing an online fundraiser to have euthanasia in Switzerland, something like that. So, the daughter of this patient sought the same thing in Switzerland for her own mother. On March 16th, 2023, I operated on this patient. It was a surgery from 9 in the morning to 4 in the afternoon without stopping. At the end of the surgery, I noticed her smiling at the corner of her mouth. I was suturing, and my brother is also a dentist. Tanto I didn't see you some time ago. He replaced one of my fillings. I spent 2 hours with my mouth open. I couldn't take it anymore. Imagine staying from 9 in the morning until 5 in the afternoon with your mouth open, operating nonstop. And she came with that smile at the corner of her mouth. And I asked her, why are you smiling? And she said, I'm not feeling pain. I said, but were you feeling pain during the surgery? She said, no, I'm not feeling the trigeminal pain. 6 months later, the pain returned. It was level 10, went down to level 4. It's interesting to understand that the body has a maximum healing potential. Not everything can be done in just one day. I talked to a friend of mine who is an anesthesiologist, explained to him about haunts inducing pain biochemically. I wanted to know what happens to the synapse after prolonged and chronic use of morphine as she had been using. Yes, this mechanism was brilliantly written in Dr. Lechner's book and saves lives. It's something I think is not often mentioned. Dr. Lechner focused more on cants, on hunts going towards cancer, but I find this incredible. The anesthesiologist told me that morphine, with its chronic use, induces pain through the same mechanism on the same receptor. And he also told me, this patient is addicted to morphine. She was. After surgery, she went from 15 times a day to 4 or 5 times. If she stopped using it, she had diarrhea, she had pain, she was addicted, she had addictive behavior if she went without morphine. So, in conversation with the family and such, they decided she went to a rehabilitation clinic, stayed there for a few months, came back without pain. After a long time, the pain returned. In June, on the 21st of June, 2024, 1 year and 3 months after the first surgery, I operated on her again. Here is a pointer, right? I operated only on these 2 regions, element 45, element 35. We see here 1, 2, 3 millimeters. 1, 2.
From the first surgery to...
The first surgery was here, extraction. This was very time consuming. And there are people who still do, right? These amputations like this. Here, everything was ankylosed. Most of the surgery was dedicated here. And extraction of the upper wisdom teeth, then amalgam and such. But that was the emergency operation, so I operated on all of this here. But normally, because of the body's healing potential, I operate on one part, wait about 2 months, then another. But her case, for me, was an emergency, right? And the pain
disappeared. And to this day, she has no pain. Just these two spots here. And now we return to our confused doctor. Element 35 in 45. Healing error, I don't have cavital, but I have a very sensitive patient to Hans. This really was a cavitation. And this case patient with a wisdom tooth, besides having the wisdom tooth in her mouth, she has vitiligo, Hashimoto's, and lupus. You see this case with the first molar, wife of a doctor friend of ours, 26 years old, chronic fatigue, healing error in the first molar. I don't know about you, but have you been noticing the amount of cavitation in the first rigid molar like this? I operate on these cavitations right here, a polylingual surgery. How will these patients be without a diagnosis? So operating on a person who doesn't have is on the brink of suicide, fine, but what about those who are? And those who have cancer? Some people kill themselves from pain. These cases are hushed up, but many people kill themselves from pain. We saw in Dr. Lechner's lecture about the relationship between Hans and cancer. We need to diagnose correctly. We have cavitations in other places that have not undergone surgery. Our dear Dr. Lechner also delved into this topic. For those who read the book, they notice that right at the beginning, he debates the issue of the term NICU. He understood exactly what the lack of a correct name causes. And as Jordan Peterson says, if they are telling a bad story, tell a better one. And Dr. Lechner went there and did that. He went there and told a better story. He gave a name, a morphological description of the shape of what we observe. Fat in the bone, necrotic in the jaw, in the maxillae. It is the form in which the pathology presents itself. But the communication problem persists, and people continue without a diagnosis. This talk, such as the place that doesn't have a problem because there was no extraction, hinders the diagnosis of seriously ill people. And I went to find out the reason for this. At the time Reggiani released the book, I read it 4 times, bought the English version, and read the English one with a focus on this issue that I had already noticed before. I read a good part of the specialized literature as well, and I wanted this diagnosis to understand the reason why professionals are not diagnosing correctly. Why does the lay public think that MECO only exists where there was extraction? I even had a medical professional who finished their postgraduate studies and came to consult with me questioning, why? I truly believe that the origin of this terrible problem lies in the use of the terms incorrect healing and incomplete healing. I'll take a few minutes here. I know it's a bit boring, but let's understand what a diagnosis is. Diagnosis is categorizing healthy, sick, normal, pathological, and the diagnosis is limited by what is necessary. As we are talking about communication error, we need an accurate diagnosis. I need you to understand what I mean by the term necessary, because I will repeat it a lot in this strict sense. In this way. It comes from the Latin necessi, meaning indispensable, formed by a negative nes, necedere, which means to yield in essence. It means that which does not yield. So, where diagnosis must be limited by what does not yield regarding the object we are analyzing, whether it is a linguistic issue or a living being. And as our professor says, the wrong language gives us the wrong diagnosis.
You will find these terms in books and articles, and I went to find out why these terms are in some articles and such. Not incorrect healing, but incomplete healing is mentioned a lot. It's in Lechner's book. And the term incorrect healing is a term from the histopathological sphere, which means a lesion that interrupted the repair process because it entered an inflammatory immune collapse. And why is there this communication error then? The communication is truncated because we have 4 distinct forms of analysis and 4 different people communicating here. We have the pathologist's description, the description in the article, the description in the book, in the classes, in practice, and in marketing. The scientist sends the sample to the pathologist and receives a report. This report contains the terms used in the pathologist's sphere, and this will be included in Dr. Lechner's scientific article. This may or may not be included in more technical books. In Dr. Lechner's case, it is included. The problem is that when it leaves the technical sphere from the technical book, it can become devoid of content. The word is being passed on without people understanding what it really means, and creates a mental image, because healing is a process and it turns into a figure of speech. So the patient or the student often doesn't know the content of the expression and ends up repeating it without knowing what it means, because it has lost all its technical content. Okay, but what is the problem? Figures of speech and ambiguous terms compromise the diagnosis. I really like a video. Even Andre said, why didn't you put the video? At a video of Jordan where he says, we have a moral burden to carry, and this burden is the adventure of our lives. We have people in pain. We have people with cancer. This has to be taken seriously. We have to take the term seriously to people. Yes, and that's why in this collection of texts there, I will publish on the website and such, I start with this issue of the linguistic treaty. I think this needs to be better detailed, and we need a more precise communication, right, that contains what is necessary. Nico is a pathology. It is a pathology in the mouth of those who have neuralgia, and it is a pathology in the mouth of those who speak out of context. The correct diagnosis of Nico is a metonymy. It is a part. It does not express the whole. No, parte. A metonymy is a figure of speech that we try to use to explain something by its part, like heads of cattle. If I say horns of cattle, something is wrong. Nico does not express the pathology. And our confused doctor, the term wrong healing has become a mental virus. He needs a new paradigm, a new way of thinking. Nothing exists in reality that is not first in the imagination, which is why words have so much power. And we at COBIC have to take the problem of cavitation seriously. We have to bring this to the CRO and the CFM seriously, not with figures of speech and convoluted talk. This has to be done correctly. And the solution begins with the nomenclature, something our Lechner saw. He dedicated a book, a good part of his book, just about this. Yesterday he talked about it. The day before yesterday he talked about it. Last year he talked about it. He is always talking about it. The same thing happens when Fischer came to Brazil. He also tries to take neural therapy to a scientific side, and there is a lot of confusion in the communication. If we talk about incorrect healing, we are talking about sickos, healing-inducing, osteonecrotic cavitation. I made this up as a joke. It's not a term I'm trying to develop. So let's define healing. Healing is a late analysis of the tissue repair process that occurs after an injury. That's what healing is. And use it as, there it is not a more linguistic analysis, but as a static object, you have something that is a process and you describe it as something static, incomplete healing, or incomplete is also static, and there is something that is a process. This creates a tilt in people's heads. No one is prepared to receive this much messy information. For stylistic reasons, I would say it was a wrong scar, not a healing, because there are two static things, but Chico is a metonymy, Chico is a part. Even though cavitation depends on injury, we cannot define something by its process. It is not the process that defines. How do we define things? We must distinguish what the Greeks called quid est, what it is. Different from how it is, different from what it is for, different from what causes it. Incomplete healing is what causes it, and this neglects the nature of the pathology. Of course, communicating is difficult. It is imprecise by definition. We must focus on the referent. For me, communication has two stages. What St. Thomas called verbo mentis. It's an idea that arises in the mind without words yet, something you can't express. And then comes what Kant said, that I find this beautiful. To make our ideas comprehensible, we must clothe them in words. And this is a huge difficulty. Everyone tries, but sometimes mistakes happen. So let's get to the quid est, what it is. Cavitation is the FDOJ. It is a disease. It is not a mistake. No one says that cancer is if you mention cancer, everyone is already alarmed. Cavitation should be the same thing. When we say error, we diminish the value of the pain a person has or the cancer they might have. It is not an error. People are not being diagnosed. That is the problem, due to the incorrect use of a figure of speech. What is the remedy for this? A matrix theory. Matrix means that which gives birth. You will soon understand what I mean. Lechner described the pathology by its shape, by the morphology. Bone, fat, degenerated, necrotic in the jaws with low angiogenesis. I will describe it the same way. We will start with a healthy jaw. We will go through a buildup of fat. The important thing is that Nico has specific foci and decreased angiogenesis. Here I highlight the region that Dr. Lechner calls 9 and what I often observe, the first molar. What evolves into cavitations? This came out more here in the image generation. I don't see cavitation here unless there are extensive extractions and such, but I don't see it. Well, before developing this reasoning, let's understand a little more about the environment of the jaw. The jaw is very different from other bones. Starting with its origin, it has an origin in the neural crest. It has a much higher metabolism than the femur, than any other part of the body. We even have a difference with these enzyme locks. I won't go too deep, but in the text I will go through each of these points and detail all of them. The collagen is not the same. LOX is an enzyme that assembles collagen in the extracellular matrix, and this is different in the jaw. One of the reasons is that also due to the high metabolism, no other bone has direct or semi-direct contact with bacteria. The non-keratinized oral mucosa, as Dr. Chokron explains very well, is permeable. We have an extremely active immune system in the jaw region. No other bone has this, okay? Comparisons between the jaw and the femur, in my view, are not that valid. And we have this. And we have that, angiogenesis, rhizogenesis, formation of third molars. None of these exists in other bones. So we can start to understand the reason why isn't there necrosis in the shin. When I started this, I asked myself, Theo, where else are there more peaks in the body? No sungti, pisiki, si. Look at the greater amount of stem cells that don't exist in any other region of our body. Metabolism is energy expenditure, the activation of these stem cells, the formation of what they are designated to form, all of this expends energy. So, or can we say that it's the same thing when we talk about the very structure of bones? We talk about mature fat cells and calcified cells. The rest are part of the waste in the trabecular bone, but it's not really the structure of the bone. When we perform an extraction or another metabolic need, we have bone and fat forming proportionally in that region with high metabolism. The formation of these mature cells comes from stem cells that depend on pathways and forms of signaling, all seeking balance. So within healthy marrow, we have this proportionality between formation, bone, fat. Let's talk a little about the forms. The forms of signaling can be through vesicles. I'll go through this very quickly here, but in the text, I will go into detail on each thing in each of these situations, right? We have the paracrine form, we have a juxtacrine form, we have endocrine and neural forms, all of this activating the stem cells forms. We have what Neto talks about with expertise, which is the mechanical form there, Neto. Where is Neto? The piezo channel. And we also have issues of polymorphism and epigenetic and genetic factors involved. Going a little smaller, we have the pathways. We have multiple osteogenic pathways. I also discuss each one there. LOX here, mTOR, but the main one is the WNT pathway. And there are studies in vitro talking about lidocaine and procaine inhibiting the WNT pathway. In fact, we have this in bone, in teeth, and in tumor cells. In the tumor, there is the WNT pathway. One of the existing studies would be in tumor issues to inhibit this pathway for cancer treatment. So, according to these articles, the process would be each having a different one. I found this interesting that procaine would be one way and lidocaine another, but it's in vitro. If you bring this to the patient, right, then it's something to consider. I go into more detail there, but here it's just to show that this exists. The mTOR pathway, gym folks, the mTOR pathway is the main one for causing developing muscle anabolism. So we have this pathway here also participating in bone activation. Thinking about the mTOR pathway, we can think about metformin. Metformin is a medication, but it's not really a medication, right? Considered as anti-aging precisely because it inhibits AMPK. AMPK is what balances with mTOR. So some articles show benefits for bone formation, but some articles also show drawbacks. If you keep inhibiting mTOR all the time, you have AMPK all the time, AMPK all the time, problem. So it's interesting to observe the patients who are coming, diabetics, the dose and frequency of metformin use.
For those into biohacking, there's rapamycin, same thing, high dose, problem with bone formation. We also have issues with aromatase inhibitors. For those using anabolic steroids, mTOR, constantly elevated aromatase and estrogen 0, it also causes problems for the bone. Imagine operating on a person like that.
Let's go back to the signaling pathways. We have pathways that are exclusive here for forming fat. Some, when suppressed, affect bone formation, while others are directly activated for fat formation. We have pathways that activate osteoclasts. We have pathways that activate angiogenesis. Dr. Lechner explained this very well in the course. When there is a dysfunction of VEGF, which would be the main pathway here, in an inflammatory environment, which we are talking about in a healthy environment for now. So, these pathways and forms of signaling depend on nutrients, hormones, mechanical activation. That's why it's recommended for a person with osteoporosis to do weight-bearing exercise to twist, squeeze the bone. Activation, there are shear forces within the bone marrow that activate WNT. Hormones. A woman in menopause experiences a drop in certain hormones and can develop osteoporosis due to difficulty in activating those pathways. Nutrients are what we have the most, right? Lack of nutrients. So here is more of a curiosity title. I found this figure beautiful about epigenetics helping in the formation of the activation of the bone. We also have something that happens a lot in the jaw, which are neural regulation pathways. And an example here is that the vesicles, when they are, the means of transmission inside them can contain genetic material, can contain other molecules that are part of this activation. When the stem cell is activated by the vesicle, nothing else changes its destiny. There is a lot of research showing that taking cells destined to form bone, immersed in an environment to form fat, and it does not change. There is a change, a genetic change in mitochondrial respiration coming from glycolysis to here and oxidative phosphorylation to form fat. It's more of a curiosity, right? So let's understand this process. We have a healthy jaw going through fat accumulation and decreased angiogenesis, but there is a step here. Before we get to the actual formation of fat, when these pathways and forms fail, they fail to activate the formation of calcified bone. And we have the development of something I call, it's not a technical term, but I gave it the name of an osteoporotic environment. I think it generates an easier visualization. This osteoporotic environment, for me, is the halfway point. It's exactly where the system starts to fail. It's collapsing. So logically, the osteoporotic environment is a reflection of systemic problems. But how do the cavitations form? We then talked about the normal environment. We understand the osteoporotic environment, low activation of bone-forming cells. The evolution of the osteoporotic environment gives us the shape. Now, when the osteoporotic environment moves to deform the fat part, it gives the shape that names the pathology. Low quantity of blood vessels, low nutrition, low angiogenesis, within a marrow with very high bone metabolism. Necrosis. For me, there is a collapse of the yellow marrow,
Soon I will talk about this issue of yellow marrow, and it necroses and is called FDOJ. So, it's interesting to understand that yellow marrow exists in the literature. The literature talks about it as a physiological aging process. But is that healthy? Isn't this bone dysfunctional? This is throughout the entire body, not just in the jaw. But the characteristics are exactly the same as in pre-necrosis, right? So, remembering the talk about what we necessarily have in the cavitations, low angiogenesis, fat necrosis, and bone necrosis. And that's what I call the matrix theory. We start with the healthy bone, understand signaling pathways and forms, failure in bone activation, increase in fats, development of the osteoporotic environment, high metabolism, and necrosis. We have a step-by-step to understand necrosis. But the matrix theory, as I mentioned, is a modern theory. It has two functions. One is pedagogical. Doctors, students, patients, they can visualize this mentally. This is how I explain this. It's practically my consultation when it's the problem of necrosis. I go there and explain this. There's a little piece of beef rib that I show to the patients there. But it works as an intellectual matrix. What does that mean? From it, we can derive intellectual development.
Let's go back to the problem of the cycle, remembering that, right? It's an irony.
Do we really have an injury developing the process? Let's say the injury happened. Did it happen here? And then, did it develop the osteoporotic environment that necrosed? Or was there an osteoporotic environment injury and then it necrosed? Notice that when I add this trauma, the essence of the theory doesn't change because trauma is an accident. In philosophy, accident means something that is contingent, that is not necessary, but it can exist. For example, when you ask someone to think of a cat, you will never think of the color of the cat, you will think of the cat. The color is an accident, not necessary. So, is trauma an accident, or do we really need trauma? That I cannot answer. But having developed this reasoning of the matrix theory, I have two insights into what I think begins to explain the emergence of osteonecrotic cavitations without tooth extraction. One I call the theory of spontaneous emergence and the other of mixed dentition. The spontaneous genesis depends on the combination of all these local and systemic factors without local trauma, without internal trauma, like a vascular problem, I'm excluding that, or external, like surgery or a blow. Remember, we talked about genetic factors. Would we have the influence of retroviruses? It's something I've talked a lot about with Sophia. I don't know if Sophia is around, but I've talked a lot with her about this issue. In theory, yes, we have a theory for the negative influence of the retrovirus on bone metabolism. In fact, the retrovirus infects the vesicle. The vesicles generated are infected by the retrovirus. And we have scientific evidence of specific viruses that cause bone problems, but they are very specific viruses. And the human T-cell lymphotropic virus type 1, we have simian AIDS. It induces systemic inflammation, for example, in this case of the bone marrow microenvironment with an increase in inflammatory cytokines, which promotes bone resorption. So there is a causality there. But within this integrative view, we are not only looking for causality, we are looking for 1% that participates. So often a recurrence is happening, something is happening, what else am I missing?
Then you come and look at this matrix theory there, and you see there's a point here that I haven't researched, retrovirus. Does he have herpes and all herpes viruses influencing? So the molecular mechanisms of spontaneous genesis activated adipogenic pathways, suppressed osteogenic pathways, failure in angiogenesis, increased fat, low bone, low vascularization. We may have collagen problems. As we saw there is the LOX, which is the glue of collagen. It forms the collagen of the extracellular matrix. The interesting thing about the class from Andre and my friend Neto, it's an honor to call you both friends, is that they provide the foundation for understanding precisely this here. Is there a problem in the matrix that is causing this collapse and direct problems in angiogenesis? There are things that decrease angiogenesis by themselves. And the fact that there is an accumulation of fat is a causal factor for decreasing angiogenesis. We see this when we kill a pig. In the fat, it bleeds very little. It bleeds in the skin, it bleeds in the muscle. Now imagine an accumulation of fat inside the bone marrow enclosed by cortical bone with stress, with metabolism, with this, with that, low angiogenesis. To me, that's what happens. Chris, we evolve to necrosis.
But I still haven't answered my question. I went to research all those texts to answer my question.
Why am I seeing this here? Theory of mixed dentition. Remember the osteoporotic environment? Imagine the osteoporotic environment here. I am not talking about the formation of necrosis in children. I am talking about the specific evolution of regions that I call the osteoporotic environment.
More eruption, as I was talking with Dr.
Neto, in eruption with imbalance and stress causing on top. Of this first molar, which I will soon talk a little more about, but we have all these stem cells at this stage activated, needing nutrients, hormones, and everything else we saw before. Spending nutrients at full speed. Everything is being activated here. So, going back to the pathways, all of this here is consuming nutrients. And with the emergence of the first molar, I believe that the trauma in a thinner developing bone, a child chewing everything with the muscle potential that is there and add whatever else you want. And there are some studies that show increased tension in these two regions here. The bone is still thin and everything is in development. I believe there may be points of tension, specifically the first molar and the region there at the angle of the jaw, which can evolve into an osteoporotic environment that persists. There's an interesting issue that comes from Anna's class, which is the transgenerational nutritional problem. We have epigenetic pathways bringing this problem, these craniofacial deformities that we see, lack of nutrients and so on, Pottinger's work, right? I found this book in a second-hand bookstore in England. It was supposed to arrive in October of last year. It arrived last week. I only read it online, but now I have it.
So we still have this here, the possibility of this.
So this is the hypothesis. Vulnerability of the mandibular bone microenvironment during a critical development phase triggers active mandibular growth, tooth exfoliation, eruption, mechanical stress, predisposing factors, local bone environment with osteoporotic characteristics, what I call there osteoporotic environment. But what I really believe is this here, look. It's the spontaneous genesis along with the mixed dentition, which is just one thing, right? If you observe, it's not, here it deals more with adults, but I believe it's coming from here to there. And a patient came to see me a few weeks ago, trigeminal neuralgia at 11 years old.
The parents are desperate with her. And then, could it be uptake? There isn't a test yet, but it might start helping to prove these things here, right?
Insights for treatment. Okay, I developed, together with Grazi from Balneario, a film that you stick on the cheek, on the mucosa, containing a microdose of melatonin, a microdose of hormones, estrogen, testosterone, a microdose of vitamin K, a microdose of magnesium. Once a day for 30 days, the patient places a microgram on the mucosa on the side where healing is occurring. You have it there in the interstice. All of this is going there. Regarding a question that was a previous doubt, many people always, like they asked each other, who operates, what is the size of the cavity? Is it small? Oh, is it wide? Research shows that during the tissue repair process, especially fractures, most of the bone-forming stem cells come from the periosteum. So a large opening and a large opening with an incision far from the center of the sausage. I have already done some tests more towards the vestibular, more over there and such. I arrived at the technique there. Because sometimes we encounter cavitations at the anal para that's been around much longer than I have, which are huge. You leave that hollow and you put a PRF there and close it. Where is the angiogenesis and everything else coming from? Periosteum. We have to treat this periosteum well, not tear it during the surgery process, not have sutures on top. In the middle of the surgical site, everything has to be far away. This periosteum has to be intact, sending information there. I also took the course with Paolo Pasquale, and I developed a technique of TCO with chopped PRF and such. I have something of my own that I'll explain another time. But there's something that no one is talking about. We have mechanical activation, hormonal activation, and nutrient activation. Where is the pre- and post-operative mechanical activation? Are we relying on the patient's chewing? So I was talking to Neto recently. There's Jonathan at the gym. We are developing a device for the patient to use preoperatively, not immediately post-operatively and post-operatively. You have mechanical stimulation happening. Tension on the periosteum helps in osteogenesis. I don't know if my professor Nogales is around, but how much ozone are we using in these surgical stores? What is the dose? Are they treating these stem cells well? I use 7 micrograms. 7 is a number kind of biblical. For me, it's great. Too much oxygenation is harmful. It's also not a good for, it's in my texts. Let me go back here. I hit it by accident. Oops, it's there. Okay. Exam question. Those who know me know that I don't like exam questions. Have you ever thought about orthodontics in an osteoporotic environment? Not the issue of cavitation formation, but the buccal plate, what's happening? Why is there no necrosis in the cortical? Because the periosteum is there, keeping it alive. You will never have necrosis in this sense in the cortical. No.
the cortical island, even after extraction, the gum closes, the cortical closes, the collapses medullary. It is a medullary disease. This bone is good. If you clean it up, it's good. Well, we always have this doubt, right? It's stuck there and all, but it's alive. Why do we have necrosis near root canal treatment and in the septum?
Creation of an osteoporotic environment, toxins consuming the nutrients that exist here, activation pathways that are nutrient dependent are not being activated, fat is forming necrosis and distant necrosis. We encounter this quite a lot. Well, I would like to take this opportunity, this is the end, to take the opportunity of what is necessary to talk about the method of our clinic. We have a clinic called Bio Veritatis. Bio means biological, veritatis means truth. And when we think about what is necessary, because we do with our method is based on doing for the patients what is necessary. We receive patients who usually come from medical referrals. So this patient comes and we do what is necessary. The method goes back to what Dr. Lehr, the Trali couple, teach us. Ulrich, Dr. Lechner. We return the patient to the doctor as quickly as possible with the patient treated. So we established and gave a nomenclature focusing on the issue of necessity. What is contingent, we don't do because we don't have time. When a patient, for example, comes from the doctors who referred them to us, but from Vivian, who is an oncologist, sometimes the patient has 6 months to undergo treatment, to undergo chemotherapy. There's no time to do it. We have to know what is necessary exactly for this case here. So our method focused on developing and analyzing exactly everything that is necessary to, we become specialists in taking the patient, solving and returning. Well, this is one of my phrases. This is just in case any doctor is here. But I believe that without biological dentistry, medicine keeps the patient healthily sick. Change the medicine to a supplement, but you don't take the focus of what's really consuming the supplements, right? Which only biological dentistry solves. So that's it, folks. I wanted to thank God, first of all. I would like to thank my team, my family, my fiancé, who must be at home with my mother, there with the rosary in hand. I know them both. The folks, many are here. They were a part of my story, made me the dentist I am. Graduated 20 years ago, but if it weren't for you, Ana, Augusto, none of this would have happened. And especially this guy is changing dentistry worldwide. What we have here, what the Trali have done, doesn't exist in the world. If you research which centers have interaction between doctors and dentists, and if my statement is true, this here is the center of a revolution that is happening. We are living at the beginning. We have to take it seriously because there are truly sick people. And many times, right, they come to us as the last hope. Because it's not even the doctor who referred them. The doctor says, go there, that's the place. And we have to be that dentist, their last hope.
Thanks.